Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the UCSF Department of Medicine. Usual ground rules today. We will, closed caption will be available. CME is available. If you are interested, stay on at the very end for instructions. If you have questions, we'll have 5 or so minutes at the end for questions. Please type them into the Q&A. And as always, this will be posted on YouTube probably in a couple of days. I'm particularly pleased about today's topic. It's in the field of hospital medicine, my own field. And as you know, hospital medicine encompasses all of the specialties of medicine, and in fact involves a lot of surgical and other specialties as well. So it's a very broad topic, but really looks at acute care issues that occur in the hospital. And we're thrilled to have an amazing hospital medicine faculty and trainees and staff here, and 3 wonderful divisions. And so today's topic is updates in hospital medicine, really take a look at the literature over the past year or so and what we can learn from the emerging science and research. Our speakers are broadly and fondly known as the 2 Brads, 2 of the most esteemed clinician educators at UCSF. The first is Brad Sharpe, who's professor of medicine in the Division of Hospital Medicine at UCSF Health. Brad received his bachelor's from Stanford, his medical degree from Harvard, came out here for residency and chief residency, and has stayed on for an illustrious faculty career with a variety of roles as a clinician educator and leader, including most recently having been the chief of the Division of Hospital Medicine at UCSF Health for about 5 years, and now focusing on his work as a clinician educator. So Brad, welcome. And along with Brad Sharpe will be Brad Monash, who received his undergraduate degree from Michigan, his medical degree from Penn, and did med-peds training at the Harvard affiliated programs. We were fortunate enough to recruit him to UCSF, I don't know, a bunch of years ago. And he has now as the vice chief for clinical affairs in the Division of Hospital Medicine, also the site director for the residents at Moffitt-Long Hospital, and the course director of the Intro to Career Launch and Coda in the UCSF School of Medicine. Really 2 of our top clinician educators in our department and leaders, and they are going to update us on what's new in the field of hospital medicine. I think Brad Sharpe is going first.
Hello, everyone. Welcome. Thank you so much for joining. Thank you, Bob, for the lovely introduction. We really appreciate it. Brad and I are thrilled to be here today, joining you virtually to present a year in review in hospital medicine. We worked hard to make this an engaging, interesting, high yield, and useful next 45 or 50 minutes as we review the literature in the field of hospital medicine. Again, an honor to be here and invited. And I want to make this high yield and useful for all of you. With that, let me go ahead and start with my slides. Do this. Give me one moment to fix my screen here. Oops, a minute to fix my screen. One moment. There we go. So this is intended to be a year in review of the literature. I'm going to start actually with a thought exercise for all of you. Here's the thought exercise that if you're anything like Brad and I, somewhere in your world, there is a stack of unread journals, right? Or maybe you get email, tables of contents emailed to you. Maybe these journal watch sitting in an email folder somewhere. But if you're like us, somewhere in your world, there is unread literature. And I can see it. I'm in my office, a stack right there. Now, every time I go by that stack of journals, I feel bad. I feel like I am not upholding my professional responsibility to keep updated on the literature. And I feel badly about that. But let's be honest, that stack of journals has some competition in life. Let's just go through some of the things it's competing with. For example, another Marvel Comics movie. It's really amazing. Maybe you're interested in watching TV, movie, whatever it might be. Maybe you're following everything COVID, which Omicron, which tweet from Bob Wachter will you be following? Maybe you're a sports fan following the 49ers or World Cup that's coming up. Maybe that stack of journals competing against politics, Supreme Court decision, midterm elections, regardless of your political affiliation, you're gripped to the news, or maybe, just maybe, you want to spend time with people you care about. So I have an 11-year-old daughter, 8-year-old daughter, and I will share with you most days, not every day, but most days, Monopoly with them is better than JAMA. That is just true. That is to say, this is hard, but that's why Brad and I are here. This is one of our academic interests, is to present the literature update to help keep all of you updated on the literature. So this is intended to be a literature update that goes from October to October each year, and then we'll update it again in the spring. The way we choose the articles, we review over 40 journals in addition to things like Journal Watch, and then we independently analyze article quality. At some point, we had to decide that we will not talk about COVID, that others will cover COVID. This is all of the non-COVID related literature in the field of hospital medicine. With that, we still had about 50 articles. So the final two criteria we used are, we chose articles that will either change your practice or confirm your practice. That we chose articles that we think that could, if you're taking care of hospitalized patients the end of the week, next week, you'll do something different, or it'll confirm something you're doing, which is you're doing it already, like, oh, now I have evidence to support that. We hope not to use any of the following words. Oop, there it is. Yeah, I don't know what those mean, to be honest. Yeah, which is to say, this is not a journal club. We'll cover the methods, we'll talk about the flaws, but trust that we've reviewed these and they are strong enough articles to either change or confirm practice. I will also add, for those of you that don't directly care for patients in the hospital, this will be high yield and useful to you to get a sense of why did the hospitalist do that in the hospital, or when they come to you in clinic, that's the decisions that were made. So again, there's articles in here for everyone. We are going to use how we're going to get there. We're going to follow a couple patients through their hospital stay. We will ask multiple choice questions. Now, let me say, we are not going to use any formal audience response, but I'm going to ask, we're going to ask. Please hold yourself to an answer. I'm going to give you options A, B, C, D. If you think it's D, like, I would encourage you to actually write it down in front of you. The reason for that is twofold. One, been test takers your entire life. If you get the answer right, there's a little dopamine surge that makes you more likely to remember it. Oh, and if you get the answer wrong, there's that self-flagellation that comes with it. So I really encourage you to commit yourself to what you think the right answer might be. We have no conflicts of interest to declare. And lastly, if you want the actual slides, you can email me directly. There's my email. I will send them to you. I'll take out anything copyrighted. The goal is to help improve the care of patients in the hospital. So I'll leave my email up there for 10 more seconds, and then I'll get started with the first case. With that, let's get into our first case. After a well-deserved vacation, you are excited to go to work and see some patients. Now, imagine, if you will, you are an attending on a teaching service working with trainees, resident, interns, medical students, and you're rounding with the team on the first day and you're hearing about a holdover admission from the night float residents. You're in a system where the residents there overnight and presenting a new admission to you. She describes a 61-year-old man with a history of hypertension, prior stroke, recurrent aspiration, and alcohol use who presented with 2 days of abdominal pain with nausea and vomiting. The pain is severe, mid-epigastric. He's afebrile, he's tachycardic, moderate abdominal pain on exam. His white count is 14,000. Lipase is 940. The resident says, I think this is moderate acute pancreatitis, likely from the patient's alcohol use. She says, so based on that study you told me about last year, I started him on a diet. We covered that last year, early feeding and pancreatitis. We're giving him intravenous morphine for pain. The ED gave him a liter of normal saline, and I started him on lactated ringers. She then says, I know, we've sort of with giving less fluid for patients with sepsis. So I wondered if the same is true for pancreatitis. Are we giving less fluid? She says, I would give like 250 an hour in a case like this, but wondering, what rate of fluids might you use for his acute pancreatitis? She's asking you that. How do you respond to her question about the fluid rate in acute pancreatitis? Here's the first question for you. Do you say A, oh yeah, no, hydration is important. That's how we prevent bad outcomes, 250 cc's an hour. B, I would give him another liter bolus and run him at like 200. C, you're right, we are backing off fluids a bit in pancreatitis. I might just do 100 an hour and see how he does. For D, perhaps, you put your teaching hat on. You put your teaching hat on. She says, what rate of fluid do you choose? And you say, what rate do you think we should choose? You could be the teaching hat. Or perhaps you're feeling a bit reflective today and you stand back and rub your chin and you say, I like to give Lasix in a case like this. Dries out the pancreas like a raisin. It's like a raisin. All right, I'm going to give you 10 seconds to think about what you would choose as the fluid rate in this patient with mild to moderate acute pancreatitis. All right. I love this study published in the New England Journal of Medicine in just September because it helps us answer one of these unbelievably common questions. You could probably imagine if you're an inpatient provider, the last patient with pancreatitis, there was a moment when you pulled up an order and you had to choose the fluid rate. Previous to this, there just wasn't much literature, 250 an hour, 300 an hour, 150. What should we do? And these authors sought to answer this question: how aggressive should we be with fluids in the management of acute pancreatitis? This was a multi-center, open label, randomized trial, 18 different sites in Europe. They looked at aggressive versus moderate fluids in patients with mild to moderate acute pancreatitis, typical abdominal pain enzymes presentation. Now, what was aggressive versus moderate fluids? Well, first, these patients were mild to moderate, so they couldn't have organ failure on admission. So no acute kidney injury, no respiratory failure. It was pretty, not that sick of a patient population, pretty standard for a patient with pancreatitis. In the aggressive arm, they got a 20 milliliters per kilogram bolus and then run at 3 milliliters per kilogram per hour. In the moderate arm, it was 1.5 milliliters per kilogram per hour and a bolus, but only if hypovolemic on exam. Okay. Now, I know what you might be saying. You're like, excuse me, I'm not good at math. Or perhaps you're like, I was told there would be no math here today. It's okay. So I'm going to do the math for you, which is it translates to this. The aggressive arm, think like 2-liter bolus and then 200 an hour for most patients. And those in the moderate arm basically started them at 100 an hour and they get a basic 1-liter bolus of hypovolemic. Weight dependent, but that's roughly the fluids we're talking about. They didn't stop there though. They said, well, let's reassess. So they had a protocol to reevaluate at 12, 24, 48, 72 to decide, do I give them another bolus, continue at the current rate, or do I actually stop the fluids? So what were the results? About 250 patients, mainly gallstone pancreatitis. To get a sense of how sick they were, only about 25% met SIRS criteria. So again, mild to moderate acute pancreatitis. They looked at 4 main outcomes: total fluid given over the first 48 hours, development of moderate to severe disease. Essentially, that's like, did the bad stuff happen in pancreatitis? Did they develop acute kidney injury? Did they develop hypoxia from acute lung injury? Did they develop a necrotizing pancreatitis? Like, did they get worse, essentially, was that outcome. They looked at assessment of fluid overload, which is both exam and point-of-care ultrasound x-ray, and then they looked at length of stay. Again, comparing aggressive versus moderate fluids in mild to moderate acute pancreatitis. Here are the results. Not surprising. Those in the aggressive arm got more fluid. They got a higher rate and they got more fluid. The development of moderate to severe disease was basically the same. So not statistically significant, but even a trend toward higher in the aggressive arm. So aggressive fluids didn't decrease complications. Also, maybe not surprising, rates of volume overload were way higher in the aggressive arm, about 3 times higher in the aggressive arm. And that was statistically significant, mainly physical exam features, JVP, crackles, edema, et cetera. And the length of stay, almost met statistical significance. It was like crossed just to 1, but a trend toward shorter length of stay in those in the moderate compared to the aggressive arm. In addition, there was a trend toward more respiratory failure, more organ failure, more necrotizing pancreatitis actually in the aggressive arm compared to the moderate arm. So what do we summarize? Aggressive fluid in mild to moderate pancreatitis led to more volume overload, no difference in other outcomes, and maybe even a longer length of stay. Now, in terms of comments, I'll start and talk about the methods of the study. So small study, they actually stopped early because they were showing no benefit, and it's open label. So the providers knew this patient's in the aggressive arm, this patient's in the moderate arm. So one could imagine that might have led to more volume overload. They know they're getting a bunch of boluses, so they look volume overloaded, but that shouldn't have impacted the other outcomes, the moderate to severe disease development. So aggressive fluids did not have a clear benefit. So I will be honest, for Brad and I, this is a practice changer. In the past, I would have been like, give this patient another liter, run them at 200, 250 an hour. But now I'm like, maybe a little bit of a bolus up front if they're hypovolemic, run them at 100 an hour, but then don't stop there. Continually reassess that being hyper-aggressive in mild to moderate pancreatitis may not have benefits and may actually be causing harm. So I would say this, for those that answered C, we are backing off fluids a bit in mild to moderate pancreatitis. Again, not when I'm talking about the patient who's in the ICU and critically ill, we probably are okay backing off, might lead to less volume overload. The case continues. Naomi, who's one of the interns, changes the rate, says, let's go to 100 an hour, and you agree on serial volume exams. The resident who presented the case says, thanks so much for the teaching, I'm gonna get some sleep. Then Naomi says, it looks like the overnight resident went with regular heparin for VTE prophylaxis. I'm looking, his renal function's okay. He weighs 80 kilograms. Should we do enoxaparin, a low molecular weight heparin, Then she pauses and says, is it actually any better for DVT prophylaxis? You decide to make this a teachable moment and you ask your entire team, does anyone know if low molecular weight heparin is actually better than others for DVT prophylaxis? Is low molecular weight heparin better? After a pause, Priyanka, who's the medical student on the team, jumps in. She says, it actually is better based on the most recent systematic review. She pulls out her iPad. She hits like 3 things, and all of a sudden up comes this article. Boom, there it is. Anticoagulants for thrombosis prophylaxis in acutely ill patients admitted to hospital, a systematic review and network meta-analysis. She shows you this article, and you're like, let me take a closer look. This is our first short take. I'm just going to cover this in a couple slides, published in the British Medical Journal. This is a huge systematic review, meta-analysis, 44 randomized controlled trials, 90,000 patients. I think this is like all the randomized trials that have looked at DVT prophylaxis in medical patients. So stroke patients, MI, this is not surgery, not post-op. This is like medical patients, randomized controlled trials. And they looked at everything, low molecular weight heparin, unfractionated heparin, DOACs, both studies that were versus no intervention, also studies versus placebo. Sort of like a summary of the best evidence for DVT prophylaxis. What are the results? Overall, the quality of the evidence was low to moderate. So it did achieve that moderate level, which means good enough to change or impact practice. This was a teaching point for me. The DVT prophylaxis didn't actually save lives. So against placebo, none of these had a mortality benefit. And the only agent that had a statistically significant decrease in VTE was low molecular weight heparin against placebo. So the only one versus placebo that had a prevented DVT was low molecular weight heparin. Then they did this cool analysis. They said, well, let's look at decreasing DVT rates and low bleeding rates. And the best agent balancing those things was intermediate dose low molecular weight heparin at the 40 milligrams daily for most patients, weight dependent, of course, had the best benefit versus harm balance. So it was more likely to decrease DVT, but also had lowest bleeding rate. So the best was with low molecular weight heparin at the intermediate dose. Intermediate dose unfractionated heparin and DOACs actually had the worst profile. So if you look at that, it was unfractionated heparin at more than 10,000 a day. So think like TID, and DOACs didn't decrease DVT that much and had actually more bleeding. So for the conclusion of this study was intermediate dose, low molecular weight heparin, probably best if it indicated for patients for DVT prophylaxis. And this one, I'd sort of done this, but now sort of confirmed that if I'm using unfractionated heparin, probably 5,000 BID in most patients. Again, weight dependent, you can take that into account, talk to your pharmacist. But then when this study showed above that rate, that it might actually be causing more bleeding and not decreasing DVT rates. So Naomi says, let's go low molecular weight heparin. You make a note, you're going to send some feedback to the admitting resident and send the article. The patient improves over the next 48 hours, but still requiring intravenous opiates, and you're slowly advancing his diet. Now, unfortunately, on the afternoon of hospital day 3, you're with the team. Naomi is notified the patient has had an aspiration event. Just to recall, 61-year-old man, history of stroke and recurrent aspiration. Now is an aspiration event in the hospital. He was completely fine, not on oxygen, eating Jell-O, and then suddenly began coughing. And now, unfortunately, he's sick. He's febrile, tachycardic, tachypnic, on 6 liters of oxygen to keep his saturations above 92%. You and the team are outside the room with the nurse talking about the plan. The nurse asks, hey, do we need to give him antibiotics for his aspiration? He's pretty sick in there. How does the team respond to this question about antibiotics for this aspiration event? How does the team respond to the question about antibiotics for this acute aspiration event? Does Naomi say, definitely, we always give antibiotics for aspiration. He's really sick in there. Paul, as the other intern, says, don't we get a sputum culture? And if that's positive, Priyanka is like, well, since this is so acute, it's probably only pneumonitis and inflammation. So there's actually I don't think there's an indication for antibiotics. Out comes the iPad. Here's the article. Boom, there it is. Association of early antibiotic therapy and in-hospital mortality in mild to moderate acute aspiration pneumonitis. She shows this article to the team. Great. And then Jean's the resident on the team. Jean's having a rough day. Do we give antibiotics for aspiration? Jean says, who cares? His IV will probably follow it anyway. I hate my job. All right, take a second to think about antibiotics for acute aspiration. All right, published in Internal and Emergency Medicine in 2021, aspiration is unbelievably common. Take a moment to think about the last time you were faced with a patient with aspiration, probably in the last week if you do hospital care. And the way I think about aspiration is in 3 syndromes. I think about as acute aspiration pneumonitis, what I call jello on the lung. It's not always jello, could be vomitus, could be whatever food, whatever it is, but acute inflammation, acute aspiration, it's inflammation, it's not actually infection. The second is true aspiration pneumonia that develops after the aspiration event, 48 to 72 hours later, the bacteria grow, then they get pneumonia. The third syndrome is pulmonary abscess. That's the person that aspirated 3 weeks ago and now presents with low-grade fever, right-sided pulmonary abscess. This study looked at that first arm, which is acute aspiration pneumonitis. Is there a benefit to antibiotics in early acute aspiration pneumonitis, that jello on the lung? Single center retrospective study, so not a randomized trial, one site retrospective study, looked at patients who were admitted with aspiration. Now, it couldn't be in the setting of CPR and they weren't critically ill, again, run-of-the-mill floor patient that aspirated. To be included, the providers documented a macro aspiration event. Now, these were at home, so imagine the family says they were fine, they were eating, they had an aspiration event, and now they're here with an infiltrate. And they looked at those that got antibiotics early in the first 8 hours, or those that got no antibiotics or got antibiotics much later, 2-3 days later. And then they try to control for confounders. Obviously, it's retrospective study. Patient A got antibiotics, patient B didn't. Let's try to control for why that might be the case. So small study, 150 patients, about 2/3 got antibiotics, 1/3 did not. And then I know when I read this article, I was like, oh, of course, the sicker patients got antibiotics, but they were actually equivalent for degree of illness. That they weren't any sicker, it was just this patient got antibiotics and this patient didn't. Again, they adjusted for those confounding factors. They looked at in-hospital mortality, antibiotic-free days, and length of stay. So in terms of in-hospital mortality, comparing early antibiotics to no antibiotics or late, there essentially was no difference. It was a little higher in the early, but not statistically significant. Not a huge surprise. Those that got early antibiotics got more antibiotics. They had fewer antibiotic-free days, kind of a weird way, but they basically got more antibiotics. And then the length of stay was actually longer, and that was statistically significant in those that got antibiotics early. So what do we conclude? In non-critically ill patients with acute aspiration pneumonitis, antibiotics had no mortality benefit, just led to more antibiotics and was associated with a longer length of stay. Now, here's what I'll say. To summarize a comment about the article, small, single site, confirming aspiration is hard to do, and clearly there's potential for confounding and retrospective study. But this confirms other small studies. There have been about 5 other similar methodologic studies that showed the same result, that generally, in patients with that acute aspiration pneumonitis, that what I call jello on the lung, the antibiotics don't actually help. And we should generally try to hold off that the patient just needs to clear the inflammation. Of course, use your clinical judgment. Sometimes you can't tell. Did they have a pneumonia brewing? Maybe the patient's particularly frail. Use your judgment, but in general, try to avoid antibiotics in patients with acute aspiration pneumonitis. So again, Priyanka was correct. This is so acute, it probably only pneumonitis and inflammation, no indication for antibiotics in this case. You all decide to monitor without antibiotics. He improves over the next few hours, which is the course you expect if it's just inflammation and pneumonitis, and he's back on room air by the following morning. But unfortunately, 3 days later, you're with the team and you're called that the patient now meets sepsis criteria. He has a new cough and hypoxia. A chest x-ray shows a right-sided infiltrate, and you now diagnose a hospital-acquired pneumonia, likely from the aspiration event. Aspiration event, just pneumonitis, no antibiotics. It's like 3 days later, now he has a true hospital-acquired pneumonia, presumably from that aspiration event. Naomi says, well, based on your teaching last year, he probably doesn't need anaerobic coverage for his aspiration pneumonia. True, that was last year. He's been here a while, so he is at risk. She's saying this, MRSA and Pseudomonas. I would go with cefepime and vancomycin for empiric coverage. You pause and you say, well, let me ask you this. Which one would you give first if you had to choose? You asked the team, cefepime and vancomycin, which one would you give first if you have to choose? How does the team respond to your question about the antibiotic order, this empiric therapy, cefepime or vancomycin? Naomi says, I think we go with the vanco, right? We have to get the slope has to get up to its concentration. Does Paul say, I don't think it matters. Time is mortality in sepsis. We got to do that. Priyanka is like, well, actually, there was a new study out this year showing a mortality benefit if we go with the beta-lactam first. The iPad, there it is. Administration of the beta-lactam prior to vancomycin as the first dose of antibiotic therapy improves survival in patients with bloodstream infections. Like, wow, that's cool. And then Jean, Jean Gene's having a rough day. Gene is having a rough day. Gene's like, oh yeah, Priyanka, did you just want to take over as the attending? Just like, go ahead. Just like, why don't you just take over as the attending? That'd be fine. All right. So I'm going to ask you, the right answer here is C, because that's the title of the article, actually. Okay, so we're going to go over this quickly. Beta-lactam or vancomycin. Love this study because talk about a practice changer. Like before the study, I would have been like, who cares? Just write for the antibiotics. Just get them in. So this study, retrospective review, 3,300 patients, 3,400 with bacteremia. So again, think of the methods. They said, look at all the patients that ultimately were bacteremic that got a beta-lactam and vancomycin. And let's look back and say, does the order matter for the patients that ultimately ended up being bacteremic? But again, this was empiric treatment before we knew they were bacteremic. Beta-lactam versus vancomycin, try to control for confounders to say, let's just look at the difference between beta-lactam or vancomycin. 66 had gram negatives, well, 45 had gram positives. That's more than 100. There is some math here because there are some polymicrobial infections. About 80% got the beta-lactam first. So more likely gram negatives, but a fair number of gram positives. And quite simply, they said, let's control for everything else. And is there a mortality benefit if you give the beta-lactam first before vancomycin in patients who ultimately ended up being bacteremic? The answer is yes. The odds ratio was about 0.5. At 48 hours and at a week. And so you're like, odds ratio, it's like a 50% decrease in mortality. Think like 8 to 4% in terms of absolute risk reductions. It's like legitimate decrease in mortality if you give the beta-lactam before the vancomycin. Wow, that's cool. Just the order, that's so easy. You're thinking about it, you're thinking about it. You're like, oh, whoa, wait, Brad, wait. What about those patients who had a gram positive? Then did it matter? Because what if they have MRSA? Then you need to give the vancomycin first. The answer is no. That actually vancomycin first did not reduce mortality in patients with MRSA. The mortality was the same. So if they ultimately grew a gram negative, beta-lactam first, lower mortality. If they ultimately grew a gram positive, mortality the same. So it didn't harm them to give the beta-lactam first if they ultimately grew a gram positive. So for me, I was like, this is such an easy one. When you put in the order, put a nursing order in that says, please give cefepime before vancomycin, please give the beta-lactam before vancomycin if you're giving them both empirically. So magical. And if you're wondering why, the theory as to why there's a mortality benefit: one, more likely to have gram-negative bacteremia; two, higher mortality associated with gram-negative bacteremia; and three, beta-lactam, ceftriaxone, cefepime, piperacillin, tazobactam go in fast, in like minutes. Vancomycin takes 30 minutes, or if red person syndrome's at play, an hour or two, and then cefapime's coming way later. So again, beta-lactam first before the vancomycin. You give the cefepime first and then the vancomycin, patient stabilizes. Now, this curious thing happens at the end of the day. Priyanka comes into the team room with a bunch of water bottles. She says, okay, I know it's weird to ask, but when is the last time all of you peed? Yes, she did say peed. Yeah. Yeah. Uncomfortably, you look around at the residents and you're like, can't remember the last time I peed. And then Priyanka's like, you might be at risk for acute kidney injury from hypovolemia based, at least on this study. Out comes the iPad again. There it is. Urine output at an intensive care unit, case control, 2010. So keeping you updated from a decade ago. I love this study. Urine output among 18 residents, house staff, was recorded over a 1-month period. Urine output of their patients was also recorded. They defined patients were oliguric if they had less than 0.5 mils per kilogram. Basically, I think that's like 200 cc's, 150 cc's over 6 hours. Actual acute kidney injury was if they were less than that for more than 12 hours, which is like basically like peed a soda can over 12 hours, meant they were at risk for acute kidney injury. This is a real study, by the way. Providers were actually oliguric in 19 out of 87, 22% of shifts. The residents were oliguric. They were in acute kidney injury in 1% of shifts. That's correct. Basically not peeing all day. And when compared to patients, providers were more likely to have oliguria with an odds ratio of 2. Here's the good news. Among providers, we know that acute kidney injury in the ICU associated with mortality. The good news is mortality was low among the providers. That was good. That was good. So we're going to take this and punch it. We're going to hydrate. We're going to hydrate. Don't put yourself at risk of acute kidney injury. Okay. So you realize this is the case continues, you may be at risk for AKI. You get a huge water bottle and you start gulping every 15 minutes. Now, unfortunately, you're running around, you kind of overdo it and you drink more than 2 liters in the next 90 minutes. Now, then what happens? You suddenly realize you're like, I'm having trouble concentrating. I'm like sending messages to the wrong intern, feeling a little fuzzy. Like, what's going on? Your bladder is about to explode. You run up to the bathroom and you wonder if urinary retention might have led to the cognitive decline. In fact, you're wondering if severe urinary retention is like sleep deprivation or drinking alcohol. Severe painful urinary retention is equivalent to what blood alcohol content? 0.02, 0.05, 0.08, 1.02, or maybe too much coffee this morning. Right now you're saying, wow, I have to pee, so I love this study. Published in my favorite journal, Neurourology and Urodynamics, back in 2011. Healthy adults drank 250 cc's of water every 15 minutes. They performed a bunch of tests, motor tests, visual, memory tests, and then basically they peed when they couldn't hold it anymore. Keep going. Here's what the curve looked like. The top curve is urge to pee. The second curve is pain. So there they are, they're doing fine. Then, oh, I have to go. Then they go, urge to pee and pain go down. The question is, what impact did that have on cognitive function? It had a negative effect on attentional and working memory that was equivalent to a blood alcohol level of 0.05. That's why painful urinary retention was halfway to being drunk. The good news is cognitive functions return to normal after pee. So that's good. Okay. So it is, in fact, severe painful urinary retention equivalent to a BAL of 0.05. What are the implications? Number one, just pull over for those that take road trips. You're like, oh, next rest stop, 33 miles. I can make it. No, don't do that. Don't do that. It's like driving drunk. Two, pee at work. If you really have to pee, just go to the bathroom. And three, you realize why that 80-year-old with BPH who's got a liter retained in their bladder, why they might be confused. Yeah, you can imagine if that's equivalent to a BAL of 0.05. So the case goes, you pee, you feel better. Priyanka's like, oh, I'll send out a summary of the key teaching points for the day, no problem. And then you get started on her letter of recommendation for residency because she crushed it. And here's what she sends out. Consider moderate fluids and mild to moderate acute pancreatitis. Consider low molecular weight heparin may be best at risk-benefit ratio. Avoid antibiotics and aspiration pneumonitis. Give the beta-lactam first before vancomycin and then hydrate, but not too much. And pee. And with that, I'll stop sharing my slides in the 10 seconds we have while we flip over to Brad. I want you to ask yourself one thing you learned or one thing you'll do differently based on what I've shared, and then we'll let Brad take us through the second case.
All right, is my volume okay, Brad? Fantastic. All right. What an exhilarating morning, Brad. Thank you for walking us through your morning on rounds with some outstanding trainees. At UCSF, we have a teaching service, and then we have a direct care service called the Goldman Medical Service. Now, after you had this exhilarating stretch, working with some truly impressive trainees, now you're excited to be, venturing out on your own. You're on the Goldman Medical Service, and you are taking care of patients directly. You're called by the emergency department to admit a 55-year-old man who has right upper quadrant pain, and he's found to have acute cholecystitis. The patient has a history of heart failure, iron deficiency anemia, and atrial fibrillation managed with apixaban. Surgery sees him in the ED, and they say, admit to medicine for him to cool down, and we're gonna do a cholecystectomy prior to discharge. Okay, sounds pretty straightforward. You got this covered. You hold his apixaban, you start him on antibiotics, and you make him NPO, and you plan to continue supportive care. Now, there's a lot of things we say in medicine that I absolutely love. Supportive care is one of them. I suspect if I could see a show of hands, many of you administer supportive care all the time. Now, I've looked high and low for a definition of supportive care. Think for a minute if you know, because I'm going to show you the formal definition of supportive care in about 5 seconds. The formal definition of supportive care, here it is, IV fluids and friendly banter. So that's supportive care. All right, so you're like, okay, we're gonna do that. I got that covered. Now, within minutes of admitting the patient, you receive a critical page from our clinical documentation colleagues. Here's the page. Your patient meets criteria for severe protein malnutrition. Please document that immediately. All right, it's been a busy day. Now you're not sure if the patient needs to cool down, the gallbladder needs to cool down, or you need to cool down. But there you go. You go ahead. You're gonna help the health system out. You're gonna make sure that you document appropriately for your patient, as we should all be doing. And then all of a sudden, Priyanka walks by. You're like, Priyanka, what are you doing here? What's Priyanka doing here? And Priyanka says, hey, did you know that dietitian consults save lives? And you're like, Priyanka, come on now, dietitian consults save lives? You think to yourself, all right, I'm going to show Priyanka wrong. I know she has this fantastic letter of recommendation from Brad Sharpe, but I'm actually going to prove that Priyanka is imperfect. All right, so you find this paper, hoping to prove Priyanka wrong. This was published in Journal Hospital Medicine this year, and the study investigators asked the question, can inpatient nutrition interventions really make a difference? All right, so this was a systematic review and meta-analysis. They looked at hospitalized patients identified on standard screening platforms as either malnourished or at risk of malnutrition. And they looked at all nutrition-related interventions, okay? This parenteral, enteral, PO supplementation, consultation, and counseling. And they looked at a wide variety of outcomes, with the primary outcome being mortality. But as you can see on the slide here, there was a host of other outcomes that were assessed. All right. So they found 11 randomized controlled trials that met their criteria involving almost 4,000 patients. And they really divided these into two sort of buckets. There was patients who received specialized nutrition care, and this again was consultation, counseling, and other pharmacologic interventions. And then they had patients who received increased protein provision via parenteral nutrition, enteral, or oral supplements. Okay, but then they looked at all of these together combined. And here's what they found, all right? As a reminder, their primary outcome was mortality. I personally did not expect to see a difference in mortality from nutrition engagement, but boom, there it is, a 21% relative risk reduction in mortality for engaging our dietitian colleagues. All right, so those of you who looked at forest plots before, here's what the forest plot looks like from a randomized, from a systematic review. To the left of your screen favors treatment, to the right of your screen favors control. And as you see here, the results are significant, favoring nutrition intervention. And you'll also see on this slide that the results were heavily skewed by this 2019 study. This was a Swiss study involving over 1,000 patients, a really well completed randomized controlled trial, showing the impact of nutrition intervention, a 21% relative risk reduction in mortality from nutrition intervention for hospitalized patients. All right, what about those secondary outcome measures that they looked at? Well, they found a slight improvement in quality of life. The strength of the evidence was less robust. And then as far as the other metrics like length of stay and readmissions, they found no significant difference with nutrition intervention. But again, 21% relative risk reduction in mortality. Impressive. So based on that, you order the patient, boost with meals, you consult your local dietitian, and you head out for the evening. The next morning, you get a page from the patient's bedside nurse who says to you, the patient's SpO2, the pulse oximeter, reads 92%. But since he's Black, I'm concerned he might actually be hypoxemic. And you think to yourself, what? Could there be racial bias in pulse oximeters? All right. So it turns out that we've known about racial bias in pulse oximeters since as long as since 1990. A lot's been published on this. Here are just 3 studies from the last year that have been published on racial bias in pulse oximetry. I'm going to focus on the bottom study here from BMJ. The top studies are looking at critical care populations and surgical populations. Because this is a talk focusing on hospital medicine, the study investigators in this BMJ article were really looking at like an acute med-surg population, so predominantly patients who are cared for by hospitalists. All right. So these study investigators asked the question, does a patient's race impact the accuracy of their pulse oximetry? This was a multi-center retrospective cohort study looking at greater than 30,000 paired SpO2, SaO2 ratings. Now again, SpO2 is the non-invasive pulse oximeter that our patients are wearing, and the SaO2 is the arterial saturation of oxygen, which is obtained via ABG. Okay, so they looked at greater than 30,000 paired readings on med-surg units at Veterans Affairs hospitals across the country. To be included, these paired recordings needed to be within 10 minutes apart, okay, within 10 minutes, just to make sure that like you're actually looking at the same measurement. And patients were excluded if they had any ICU level care that day. Again, they wanted to focus on hospital medicine patients. And if they had any readings less than 70%, concerned that maybe if this was an SpO2, it was inaccurate, or if it was an SaO2, maybe we're looking at like a venous blood gas sample, for example, because again, these were med-surg patients, so patients shouldn't be having oxygen saturations less than 70% on the floor. All right, so the outcomes that they looked at were 1, occult hypoxemia, and now they define this as having a SpO2 greater than 92%, with an SaO2 less than 88%. And they chose 92% as their threshold because greater than that, we're less likely to be prescribing oxygen. So they really wanted to have a clinically meaningful outcome. And so they chose 92% on pulse ox, realizing that like, hey, Patients greater than 92%, we're probably not giving them supplemental oxygen most of the time. Now, secondary outcomes, what they said is that, okay, what's the probability of occult hypoxemia on second paired measurements? In other words, if that first pair matches up, right? And they're like, okay, these correlate really well. Are you off the hook and you no longer have to worry about subsequent pairings being inaccurate or not matching up? So that was their secondary outcome. All right. So as far as their primary outcome, I'm going to orient you to this graph. What you're going to be looking at is the probability of occult hypoxemia according to the pulse oximetry readings on the x-axis there. Now they're looking at this if the paired readings of the SpO2 and SaO2 were 2 minutes apart, up to 5 minutes apart, or up to 10 minutes apart. All right, I'll show you the data now. There it is. So for all readings, okay, patients who are Black had a higher probability of occult hypoxemia than patients who are white. Now, they found similar discrepancies in other populations, such as in Latinx populations. However, it was a much smaller sample size, so they were less able to draw firm conclusions. Okay. Now, the total sort of conclusion of their primary outcome was that the adjusted probability of occult hypoxemia was 4% higher in Black patients than white patients. And as far as that, their secondary outcome, remember, like if there's correlation up front, do I need to worry about subsequent pairings? What they found was that even if there was correlation up front, Black patients had a higher incidence of subsequent occult hypoxemia, even if initially absent, 13% versus 3%. So in other words, even if you have an accurate pairing of SpO2 and SaO2 up front, you can't necessarily trust that the SpO2 is not going to be misleading with subsequent readings, okay? Now, this, of course, is highly problematic. We're long overdue to fix this problem in healthcare. The silver lining is that there are folks working on improving the technology at the bedside that is not so reliant on skin pigmentation, which is likely the significant culprit here, skin pigmentation leading to discrepancies in accuracy of our pulse ox reading. So stay tuned. We haven't fixed this problem soon enough, but the tech is in the pipeline. All right. So based on this study and your knowledge to date, you perform an arterial blood gas that reveals the SaO2 of 93%. And then just to be safe, you titrate the oxygen to a goal pulse ox of 96%. You hold his IV fluids and you initiate lung expansion efforts. Now the pharmacist who completed his admission med-rec pages you and says, hey doc, do you want to resume both his DOAC and his aspirin after the patient recovers from surgery? How do you respond to the pharmacist? All right, so this is your first audience response question. As Brad had mentioned, I want you to commit. Okay, commit to an answer. Here we go. How do you respond to the pharmacist regarding the continuation of the DOAC and the aspirin? All right, well, based on his super high CHADS2 VASC score, let's continue both. B, let's continue the apixaban, but not the aspirin. C, let's continue the aspirin, but not the apixaban. D, that's a fantastic question to punt to the PCP. So for all of my primary care colleagues out there, you know us hospitalists would never do such a thing. Or taking a page out of Brad Sharpe's book, you say to the pharmacist, do you want to resume the DOAC and the aspirin? All right, so think about this for a minute. What do you do for your patient at discharge? They recover from their lap chole, doing better. Do you continue the patient on both DOAC and aspirin or not? All right, commit to an answer. I'm going to move us forward. This is the paper that's going to help us answer the question published in JAMA Internal Medicine in the past year. All right. And the study investigators asked the question, what is the impact of combination of DOAC and aspirin in patients without an indication for aspirin? Now, this was a registry-based cohort study where they looked at anticoagulation clinics across the state of Michigan and patients who were receiving either combination therapy with DOAC and aspirin or DOAC alone. Okay. And patients were being anticoagulated for all the usual culprits, okay? Atrial fibrillation, flutter, DVT, PE, and both. And what they did is, because this is a cohort study, they did propensity match cohorts to try to control for sort of all the typical confounders. All right. So over 3,000 patients were included, and here's what they found, all right? One column there is patients who received DOAC, and the column next to it is patients who received DOAC and aspirin. So first, for all bleeding, they found patients who received a DOAC alone had lower sort of all-cause bleeding than patients on combination therapy. For severe bleeding leading to hospitalization, again, patients with DOAC had a lower risk of severe bleeding leading to hospitalization. And then for new thrombosis, there was no difference, and for death, no difference. The bleeding, however, was significant. All right, these patients had significantly less bleeding without a significant positive outcome of doubling up on the aspirin and the DOAC. So in summary here, the combination of the DOAC and the aspirin led to more non-major bleeding and hospitalization without any sort of decreased risk in overall thromboses. Now, this was propensity matched cohort study, a well-conducted study, but it's not a randomized controlled trial. But it does confirm prior data that there's more bleeding with combination therapy without real benefit seen. So my takeaway here, and this has been a practice changer for me, is to de-prescribe aspirin if appropriate. There is a small subset of patients who do warrant combination therapy, patients with LVADs or PCI with stent. Okay, so there is a small subset of patients who probably do warrant either a temporary or indefinite continuation of aspirin. But for the vast majority of our patients receiving a DOAC, we should be stopping the aspirin therapy. All right, so the correct answer here was B. However, I'll give you credit if you ask the pharmacist. I'm a big believer in interprofessional healthcare and collaboration, but hopefully you ask the pharmacist in a more friendly way. All right, so moving forward, you tell the pharmacist that you want to continue the apixaban but discontinue the aspirin. The next 48 hours go well, swimmingly. Nothing much happens. The patient undergoes an uncomplicated lab chole and is doing well until postoperative day 1. Patient develops a fever to 38 degrees. His nurse calls you and requests an order for acetaminophen to reduce serious adverse events in this postoperative patient. The recommendation to reduce serious adverse events piques your interest. Does antipyresis reduce the overall incidence of serious adverse events? With a healthy dose of skepticism, you decide to explore this question a bit. All right, and here you are with a healthy dose of skepticism. There you are. All right, let's see. All right, so this is the paper you find from the last year published in BMJ. And the study investigators asked the question, does fever-reducing therapy reduce serious adverse events and mortality? So this is a systematic review and meta-analysis of randomized controlled trials. They included all adult patients with fever, and they looked at studies comparing fever therapy with either no therapy or sham, okay? And the outcomes they assessed, their primary outcomes were mortality and serious adverse events. And their second outcomes were quality of life and non-serious events. All right. So they included 42 trials involving over 5,000 patients. Okay. And the majority of these, roughly 60% of these, were inpatients who were critically ill and had infectious causes of fever. Okay. So we're not talking about traumatic hyperthermia. We're talking about the thermoregulatory set point change that we get when we get a fever. Okay. And now the interventions here were antipyretic drugs, physical cooling, or some combination of both. And as we see in all randomized controlled trials, there are varying degrees of risk of bias. All right. So first, all-cause mortality. I'm going to show you, since now we're experts at forest plots, there's the data. I'm going to summarize it for you because, as you can see, the diamond at the bottom is right on the line, which shows no difference. There was no difference in mortality. Now, I don't think this is going to be shocking to any of us. I don't think most of us are prescribing acetaminophen to save lives, but nonetheless, primary outcome, no difference in mortality. Now, what about serious adverse events, right? I mean, come on, these are vulnerable patients in the hospital that are having fevers. Like, it's probably not good for them to have a fever, right? Well, same results for serious adverse events. There was no difference in serious adverse events for patients treated with antipyresis versus patients who were not. As far as the secondary outcomes I looked for, there was really not good evidence to draw firm conclusions. They found no difference in quality of life, but this was one trial, one randomized controlled trial looking at 37 patients. And as far as non-serious events, the data was inconclusive based on just 4 trials. So based on this data, right, you inform the nurse that you will prescribe acetaminophen for pain or for discomfort, but not just to treat that number of 38. The nurse says, okay, I gotcha. Since we're focusing on symptoms, the patient's quality of life has suffered due to his heart failure and his anemia. How about we give him some iron to pump him up? You ask yourself, would IV iron really make him feel better? All right, so how do you respond to the nurse's question regarding IV iron to treat his iron deficiency? This is your second and final question of the hour. Here we go. A, sorry, too risky because of the risk of anaphylaxis with IV iron. B, forget about it. It's not going to make a difference. C, oof, I'm worried about using his IV. Let's go with high dose oral iron instead. D, sure thing, let's pump him up. Or E, seriously, Brad, no more attempts at your witty audience response questions. Enough of this edutainment. Now, you might say, Brad, edutainment? You're making up words at the prestigious Department of Medicine grand rounds? And I'm going to tell you, no, I am not making up words. This actually is defined in urbandictionary.com. Here's the definition: an approach to education which focuses on the experience as a form of entertainment. Edutainment, there you have it. And if you're looking for inspiration as to how to evaluate this specific session, you can look no further than here. All right, so back to the question, how are you going to respond? Take 5 seconds and commit. All right. Let's see what the evidence shows. This is the paper from European Heart Journal that we're going to talk about from the AFFIRM AHF study. So what is the impact of IV iron versus placebo on the quality of life for patients admitted with acute heart failure? So this is a multi-center randomized control of patients with acute heart failure and iron deficiency who received IV ferrous carboxymaltose versus placebo at discharge in week 6. Okay, inclusion criteria, basically greater than 18, had to have reduced EF, had to have stabilized during the hospitalization, and had to be iron deficient. So they used this 12-item Kansas City cardiomyopathy questionnaire, which is a validated instrument measuring quality of life. And just to briefly summarize, the scores are represented on a scale from 0 to 100. Lower scores mean more severe symptoms and or physical limitations. And this is a really good instrument because a difference of just 2 or 3 points, just 2 or 3 points is clinically relevant across populations. All right, so we're going to look at the quality of life symptoms for patients who received iron who didn't. Here's going to be the data. I'm going to orient you on the y-axis. You're going to see the quality of life score, and on the x-axis is time. Boom, there you have it. Okay, so the red represents patients who received IV iron, the blue patients who did not, and you'll see at all time points, the patients who received IV iron had better quality of life. And that was significant all the way up to 24 weeks after hospitalization. Pretty impressive. So based on this, the conclusion was in patients with acute heart failure and iron deficiency anemia, IV iron improves quality of life and the benefit lasted for 6 months. This was a very well done randomized controlled blinded study looking at a validated quality of life instrument. IV iron is known from other studies to also decrease readmissions and improve ejection fraction. And so this also for me was a practice changer. If I have patients that are admitted to the hospital with acute heart failure and iron deficiency and they've improved and ready for discharge, I administer iron prior to discharge when feasible. All right, now some of you might say, well, what about the risk of anaphylaxis with iron? Well, this was studied this year as well. This was a retrospective cohort study using Medicare data of over 160,000 patients treated from 2013 to 2018. They looked at the incident rates of anaphylaxis with IV iron per 10,000 doses. There are the data. As you can see, anaphylaxis is exceedingly rare. And in fact, only the bottom two that have asterisks there were patients who actually needed to be hospitalized based on their allergic reaction. So these formulations of iron are safe to administer. And if you have questions about delivery, please contact your local pharmacist. All right, so the correct answer is sure thing, let's pump him up. And if you're tired of my humor, I will not blame you. Hans and Franz, let's do it. Let's do it. Let's pump up our patients. All right. So you order IV iron sucrose to be given at discharge. You complete the anthology of discharge paperwork, and you click that discharge order precisely at 11:59 a.m., making everybody happy. In summary, all right, consider implementing nutritional interventions for patients who are malnourished and at-risk hospitalized patients. Consider the limited reliability of pulse oximetry in patients with darker skin and borderline pulse oximetry. Consider avoiding the combination of DOACs and aspirin in patients without an indication for aspirin. Remember, LVAD, PCI. Consider that fever-reducing therapy does not reduce serious adverse events or mortality. And consider administering IV iron, the newer formulations for patients with heart failure and iron deficiency anemia. For spaced learning, we're going to remember Brad Sharpe teaching points. Remember moderate fluids and mild to moderate acute pancreatitis, that low molecular weight heparin is might be best for DVT prophylaxis. Avoid antibiotics and aspiration pneumonitis, the jello in the lung. Give that beta-lactam before vancomycin when treating empirically. Hydrate and pee. What a day. All right, so you finished, you've concluded, you've taken great care of patients. On your way out the door, your colleague asks you if you're doing anything for the holidays. Just dinner with the in-laws, you say. Are you sure about that? She responds. Could be detrimental to your health. You offer a courtesy chuckle. Okay, you're like, okay, in-law jokes, way overblown. But she says, no, really. And then she pulls out this paper. The effect of having Christmas dinner with in-laws on gut microbiota composition. Huh. All right, one slide of background. What is this business? So there's emerging evidence, as we've seen in DOM grand rounds, of the role of intestinal microbiota in physical and psychological health. All right, so on one end of the spectrum, the gut microbiome matters. But why do the study investigators care about Christmas dinner? Well, this background was taken from their study that I will share with you. The study investigators claim that Christmas and feces have a long-standing mysterious connection. And in their paper, they refer to first El Caganer, which is in the nativity scenes throughout Spain, Italy, and France. It turns out this is symbolic of fertilizing the earth. Beyond that, they refer to the etymology of the word mistletoe, which comes from the Anglo-Saxon mistle meaning dung and tan meaning stick. And then finally, they refer to a much more recent cultural phenom. For those of you familiar with a small-known show called South Park, they referred to the lovable character of Mr. Hanky the Christmas Pooh. All right, so again, this is background provided by the study authors, not my own. And here's what they found, okay? This was a prospective observational study of 24 participants, 14 women, 14 men. 16 had dinner with the in-laws, 8 with their own family. They collected fecal samples on December 23rd and December 27th, and they used ribosomal DNA sequencing on the samples. All right, here's a visualization of their data. First, patients who ate with their in-laws had more suppression of biodiversity in their biome, and then they looked at different populations across these 7 species. I'm gonna summarize their findings in one slide and the next slide. All right, so what did they find? Patients who visited their own family as opposed to their in-laws had greater biodiversity after Christmas dinner, which biodiversity is associated with greater host health. And they found that patients who visited their in-laws had lower levels of ruminococcus species. And it's known that psychological stress and depression lower the ruminococcus in our gut microbiome. All right. So their conclusion was that Christmas dinner with one's in-laws is associated with decreased biodiversity of the gut, which are markers of poorer health compared with Christmas dinners with one's own family. So you go ahead, you go to your in-laws, you have a wonderful time, and then you contemplate taking a pill after dinner. I will stop my screen share.
Thank you to you both for terrific, entertaining, useful, interesting grand rounds. We only have a couple of minutes. Let's do a couple of quick questions. Brad Sharpe, pneumonitis to pneumonia, like the patient you said might have a fever and infiltrate, short of breath. We're going to somehow withhold antibiotics. And I think you also said that at some point, all of that stuff we define as pneumonia, they need it. Like what day and what markers tell you they've crossed the line?
Great question. So again, this distinction between pneumonitis, jello in the lung, just inflammation. If you think about the pathophysiology of pneumonia, there's bacteria in there, but they're not actually causing any damage with the pneumonitis. If it develops into a pneumonia, the rates of that are actually less than 25%, so relatively uncommon. It's typically 48 to 72 hours after the pneumonitis event. And then that presents like a typical pneumonia, fever, shortness of breath, cough, infiltrate. But the course should be pneumonitis, get better, and then they worsen again 48 to 72 hours after the bacteria have had a chance to have their party in the lung and grow enough to cause true pneumonia. So you'll see it days later. Pulmonary abscess is, again, more anaerobic, weeks later, often someone who didn't, maybe intoxicated and had vomit and presents 3 weeks later. So that often is a different presentation altogether.
Great. Brad Monash, we have only time for a couple more. Any idea what happened during these nutrition consults that was valuable for the patient?
Yeah, I think it's actually the heightened focus on the importance of nutrition in patients' health and well-being. So a lot of it was nutritional interventions, but then it's creating that problem that, we got problem of heart failure and pneumonia. It's actually creating a separate problem of nutrition and dedicating resources and time and energy to addressing that problem to then help the patient's other medical problems. Again, this was a systematic review and meta-analysis, so we're combining a whole bunch of different interventions, including increased protein intake, as well as consultation and counseling. But it's probably some combination of all of these and focusing on the patient's nutritional status.
Okay, one more for each of you. Trying to figure out how the pulse ox thing changes practice. Are you doing blood gases on every Black patient with a?
I worry about this. I worry about this. This keeps me up at night, and I think why do I present this study? Because I think just raising awareness of bias in our measurements is critical. How this changes management is, it keeps me up at night, because I think what really is important is we need to change the technology. And the idea that all of a sudden we're going to subject all of our patients with darker skin to like tons and tons of blood gases. I just have a higher index of suspicion if the patients have borderline, if things aren't matching up, because there are other studies showing worsened organ dysfunction and mortality based on these discrepancies. So, there's other studies showing that using a target of 96% in hospitalized patients is safe. So I might have a lower threshold to actually just target 96% if patients are acutely ill in the hospital, if they're acutely ill with pulmonary pathology. But I have a checkbox and I say, do I trust this reading? How's the patient acting? Are their labs making sense? Am I seeing organ dysfunction? And what's their level of dyspnea and comfort?
Great. Last one, Brad Sharpe.
Yep.
The beta-lactam before the vanco, is it because it's the order that matters, or is it because the beta-lactam is too late?
Ooh, thank you, Bob. So again, studies showing beta-lactam before vancomycin. They tried to tease that out. I think it's that it's just too late, that it's the order doesn't matter. If you have two IVs or centralized, like if you can put them in at the same time would be fine, because we know from previous literature that every hour delay in antibiotics from onset of sepsis, every hour delay in antibiotic administration has a mortality cost. It's often in the 2 to 3% per hour. So the idea is that you're waiting an hour or two for the beta-lactam. But yeah, this just logistically it's the order, but it's more the timing of getting the beta-lactam in quickly.
But if, I don't know if this ever happens, but the vanco comes up to the floor fast for whatever reason and the beta-lactam's not there yet, you tell the nurse to wait on giving the vanco? Good
question. I would try to figure out how good news is most units have the common antibiotics on the unit, driven by patient safety, driven by this concern. I would honestly, then I might use my suspicion, which we didn't talk about because this was a 3,000 patients of, am I more worried about a gram-positive infection, central line infection, or am I more worried about pneumonia or abdominal process? That may then guide, do I say just give the vanc or let's wait for the cefepime? That makes sense, a little more subtlety to the question.
Great. Okay, we're a little over in time, so we will quit. Thank you, folks. Terrific and instructive and fun. And we'll be off next week for Thanksgiving and then see you back again the week after. You should have a wonderful holiday with your in-laws, or not. See you later.